Thank you, everyone, for being here this evening. My name is Anna Knoll, and I direct TFI, or Transformation Freedom Initiative, where we work to empower against exploitation by raising awareness and prevention of human trafficking. And we mainly focus in Central Virginia and parts of the Valley, but I'm so happy to be able to join MSV over Zoom to give a presentation tonight on human trafficking in the healthcare context, because that's a lot of what we do at TFI is giving information on human trafficking within someone's specific context of life, whether that's as a parent, in your job, for young people, youth programs, to help people understand what this issue is, how it might present in their specific context, and then what are practical action steps to take when it comes to prevention and intervention. So I'm just so happy to be here with you all this evening and for our second training with MSV. And as I mentioned, this presentation is on human trafficking in your context as healthcare professionals. And I do always like to give a shout out to my colleague, Laura Lederer, who truly created this training. And the information in this training is from the first retrospective study of the health consequences of human trafficking, which was designed and conducted by Laura. And so TFI was able to obtain this training from her and to tweak it and modify it over the years to really reflect what we're seeing in the anti-trafficking movement, using that crucial data that Laura was able to gather. And so just to give you a little roadmap of what we're going to talk about together, we're going to be going over, what is human trafficking? We're going to talk about what the health implications of human trafficking are, how you can identify those indicators both in the healthcare setting and from individuals and patients. We're going to talk about a trauma-informed, victim, person-centered, and multidisciplinary approach to working with patients who might be victimized. We'll look at how do we assess survivor needs, which will be unique based on each survivor and based on their particular needs. And then look at how do we refer and offer services that are helpful. What are some of the laws and policies around this issue? And we will also have some time at the end for a Q&A. And during the presentation, just as some housekeeping, there might be times where I ask a question and you can put your answer in the chat, which Taylor and Chris will be monitoring for me and let me know what you all are saying. And then also at the end during the Q&A, you can put your questions in the chat as well, so we can be sure that we're answering any thoughts that come up. And before we jump into this topic of human trafficking, I do just want to give a trigger warning and encourage you to practice self-care during this time. This is a heavy and intense topic that can easily, trigger our own trauma. It can also cause secondary trauma. So I just encourage you to, do what you need to do during this time. Step out, mute, just whatever it is that you need to do to practice self-care. But it is crucial that in our time together, we start with what is human trafficking, because there are a lot of myths and misinformation that gets spread on this issue. And so before jumping into the definition, I want to do a myth or fact activity to see how much you all already know. And during this time, you can put your answers in the chat, but I'm going to be giving you a statement, and I just want to hear, do you think it's a myth or a fact on this issue of trafficking? So first, is it a myth or fact that all human trafficking is sex trafficking?
We've got several myths.
Okay.
Actually.
Awesome. So we have an informed audience here. So that is a myth. So experts actually believe that there is likely more labor trafficking than sex trafficking worldwide, but we tend to talk more about sex trafficking, and we're learning more about labor trafficking. And in this topic of human trafficking, we find that numbers tend to follow awareness. And what I mean by that is it can be easy to, look at statistics on trafficking and go, wow, the numbers of victims are really going up. But in reality, it's usually that our awareness of the issue is going up. And so now we're actually seeing the issue and we're able to report on it. And those data points are able to get collected. So just something to keep in mind as we go through our time tonight. So next myth or fact, men and boys are also victimized by sex traffickers.
All facts from folks.
Wonderful, wonderful. So the stigma around boys being victimized can cause there to be lower statistics again on whether boys are sexually exploited. But we've seen different programs say, when we adjust our programming to care for sexually exploited males, those identification rates do jump. And I was actually at a training recently that talked about how over 60% of minor male victims are sex trafficked. So it is a major issue for the male population as well. Next myth or fact, human trafficking is always or usually a violent crime.
We've got a mix of myth and fact for this one.
Yep.
Yeah.
Yep. This one is tricky. So this one is a myth, actually. So it is the most pervasive myth about human trafficking that, there's some sort of like kidnapping or physical force involved. But we're finding that most trafficking situations involve psychological means of control by the trafficker with, tricking, defrauding, manipulating. And that's because there is a grooming process that takes place to build a trusting relationship with a victim in order to exploit them more effectively. And this can lead to, the logical question of, well, then why don't victims leave the situation if they're not being physically held back? And I love to just point out this quote that really lays out how some victims don't have the basic needs that they need met in order to leave. Some are afraid because they've been threatened. And sometimes victims are so effectively groomed and manipulated that they don't realize their victimization because their trafficker is their spouse or their boyfriend or girlfriend or a family member. And so it can make even self-identifying this issue very difficult. And I also like to show this power and control wheel on sex and labor trafficking because it breaks down how in the grooming process, there are both overt and subtle traumas inflicted on a victim over time. And this happens by offering hope in the midst of abuse and manipulation. And the trauma that this causes on a victim of trafficking has a physical impact on the brain. And so there's a rewiring in the brain that occurs that also influences how a victim is surviving moment to moment. And this can cause someone to not be thinking so much about how do I get out of this situation as how do I get through this moment. And so that can kind of shed light on why a victim wouldn't just walk away as well. But we have a few more myths or facts here. So the next one I want to ask is human trafficking. Is it the same as human smuggling, or human trafficking is not the same as human smuggling, myth or fact?
Got fact and myth.
Very good. So the way I phrased that was a little confusing at first, but it is the fact that trafficking and smuggling are two different things. So smuggling has to do with illegal border crossings, which can be done by choice by an individual. There are cases where someone is being smuggled in order to be trafficked or being smuggled as a trafficking victim, but they aren't the same thing because to be trafficked, you don't have to be moved. You can remain in your own hometown, your own home. And so no movement is required for this issue. But another myth or fact, traffickers target victims that they don't know.
All right. We've got myths and a couple of, oh, nope, just all myths.
Awesome. Very good. So like I alluded to, a lot of survivors are trafficked by someone that they know and trust, like a spouse, a family member, parents. But this doesn't mean that traffickers always know the person that they're going to victimize. They might target a person and then they go through that grooming process and they take their time building trust with their victim over time. So by the time that they are exploiting the individual that they've chosen to victimize, the survivor feels like they do know their trafficker and they do trust them. And so what a victim might initially agree to in a trafficking situation is usually not what ends up happening to them. And so this creates further complication as well. But thank you all for going through that little activity with me. Now I just want to kind of go over, okay, what are the facts of human trafficking? What is it really? And as you can see here, this is the Trafficking Victims Protection Act, or the federal definition in law on human trafficking that covers sex trafficking as well as labor trafficking. But to simplify this definition, when we talk about human trafficking, we're talking about the use of force, fraud, or coercion to obtain some type of labor or commercial sex act. And we can break this down further into what is called the AMP, or Action Means Purpose model. So to legally prove that trafficking has occurred, we have to prove there's been an action of inducing, recruiting, harboring, transporting, providing, obtaining, or in the cases of sex trafficking, patronizing, soliciting, or advertising an individual using force, fraud, or coercion for the purpose of sex or labor trafficking. Now, again, we typically think of force. We think of movies like Taken and all the information that our media tends to spread about trafficking. But again, fraud and coercion are much more commonly used because traffickers recognize that if they can gain control of a victim psychologically, they're not going to have to worry about that person leaving. And so they're not going to have to worry about that money leaving either. And so when we think of trafficking, we want to think about, this is a complex trauma that's occurring. This is a trauma bond between victims and traffickers, as well as victims with other victims. And so there's a lot of complication and a lot of psychological complication with this. Now, I will say there is one caveat to this model when we talk about sex trafficking of children. And I'm going to get into that more in a few slides, but just keep that in mind. Some other facts I like to go over when talking about trafficking is that it's estimated that about 40+ million people are enslaved worldwide. Again, when we're talking about statistics, those numbers are probably lower than the reality just because of awareness. But it does make $236 billion a year. Now, I was just updating this number today because it used to be $150 billion. And a recent article that came out showed that human traffickers, their illegal profits are at $236 billion now. And to put that in perspective, that is more than the annual profits of Walmart, Visa, Amazon, Google, and Apple combined. So it's a major lucrative industry, in which when we look at our next fact, it makes sense that it is the second largest criminal industry worldwide. So another question I want to ask that you can put your answer in the chat too is, what do you think is the largest criminal industry in the world?
We have a lot of drug trade, all drugs.
Very good, very good. Yes, this is a very informed audience, so it is drug trafficking. But what I want to know next is, why do you think, so experts are saying that they believe human trafficking is going to surpass drug trafficking in the near future. Why do you think human trafficking is going to replace drug trafficking?
We have population increases, it's sufficiently hidden, less penalties, and drugs are becoming legal, and awareness.
Oh, sorry, go ahead, Taylor.
I was just saying awareness is listed a couple of times as well.
Awesome. Awesome. Yeah, all really good answers. And all of that, I think, ties into why it's going to surpass drug trafficking. But at the root of the, answer to that question is that With drugs, you can only sell them once, but when you're selling a person, you can sell them over and over and over again and make a lot more money on that individual. And so that is where surpassing drug trafficking, that is where the root of it goes, is how much money can I make on this interaction? So really good guesses. And drug trafficking and human trafficking are also just closely related because sometimes traffickers will traffic a person in order to traffic their drugs. Sometimes a trafficker will use drugs to either maintain control of a victim or exploit an existing addiction that they have to maintain control. And so they do go together as well. But the main types of human trafficking that we see in the US are, again, labor and sex trafficking. And with labor trafficking, again, we can look at that AMP model. So there is an act of, recruiting, harboring, transporting, etc., using force, fraud, or coercion for labor. And so examples of coercion when it comes to labor trafficking includes things like threats of force, serious harm, psychosocial harm, debt manipulation, which it usually looks like, well, I got you to this country, or I got you this home, or I got you this job, and now you owe me, withholding pay, taking identity documents, which I recently learned when holding someone's passport in Virginia, that is actually considered a form of abduction and is commonly used by traffickers to control their victims. It might look like psychological coercion, reputational harm, again, manipulating addictive substances against a victim, and threats to other people that that victim loves. And so all of this is being done to coerce this individual into providing those labor services. And it can happen in any industry, both legal and illicit. So this might happen in the agricultural industry, in factories, restaurants, hotels, retail stores, in homes, in drug trafficking operations. But all three elements of action, mean, purpose do have to be proven in order for a crime of forced labor to be brought against someone. Now, because we're learning more and more about labor trafficking, I do like to highlight two types of labor trafficking that occur, just to give us an idea of how this can look in the US. So the top form of labor trafficking in Virginia, according to the latest National Human Trafficking Hotline statistics, was domestic work. And so, this is when an individual is being required to work in a private residence. This could be, doing housework, maybe childcare, and they are alone. And the employer is controlling their access to food and transportation and housing, and they're hidden from the rest of the world. So it's more difficult for law enforcement or labor inspectors to identify this issue. And foreign domestic workers are especially vulnerable here because of language barriers and cultural barriers and not having community ties where someone might notice, hey, this person hasn't been around lately. And so traffickers will use this against victims. And when we're thinking about foreign domestic workers as well, there are many other threats brought against them by traffickers. If someone has come here to escape violence in their home country, a trafficker might threaten to report them or threaten deportation. And those threats become just very powerful against a victim in that situation. And so that's where understanding laws around this is really crucial as well, because there are laws that can protect victims of trafficking, even if they, are not legally in the country. And so there is help available in those situations as well. But I also like to highlight, forced child labor, because children, both in sex and labor trafficking, are disproportionately targeted because they have unique vulnerabilities. And the average age of a trafficking victim in the US is 12 years old. And so we are seeing that there are just these inherent vulnerabilities to being a child, but forcing children to work, even though there are settings where a child can work legally, forcing them to, or them working in horrible conditions and being denied food and rest and schooling, that is all forced child labor and is illegal, but it is prevalent as well. So important to keep those in mind. Now, when we talk about sex trafficking, again, we're looking at that action means purpose. There's an action of harboring, soliciting, engaging someone by force, fraud, or coercion for the purpose of commercial sex. And all of the types of coercion we talked about in labor trafficking also happen in sex trafficking. A lot of reputational harm. I'm going to tell your family what you've been up to. I'm going to report you to, your boss, or, I'm going to target someone you love if you don't do what I'm telling you to do. So lots of ways that this blackmail and manipulation occurs. But again, the purpose is commercial sex. But I like to say, the ultimate purpose for a trafficker, whether it's labor or sex trafficking, is money. It's not about the labor and it's not about the sex. It's about the money the trafficker can make. And we talked a little bit about where labor trafficking is happening, but for sex trafficking in Virginia, the top 5 venues were in massage and spa businesses, in hotels, pornography, escort services, and residence-based commercial sex, which we'll get into a little bit more in a few slides. But I also like to point out that the internet is a top recruitment method, no matter where you are. So sex trafficking does not require any kind of physical contact. It does not require the act of intercourse. It can be through pictures, videos, completely through social media. It could be, a young person just in their room on their device being manipulated in these ways. And so we have to keep that in mind, and keep in mind that it's not just the exchange of money, it's the exchange of anything of value. So some victims don't self-identify because they're thinking, well, there hasn't been any money exchanged for me. But I'm sleeping with my landlord to pay rent, or I'm, sleeping with this individual so that they will offer me food and clothing. And so really breaking down that it's not just money directly is important as well. Now, as I mentioned, all commercial sex involving a minor is legally considered human trafficking. And this is crucial to understand because we often hear this term child prostitute, right? And so I'm sure many of you have heard that term child prostitute. And what's important to keep in mind is that by law, there is no such thing as a child prostitute. Even if a child is willingly engaging in commercial sex, you do not have to prove force, fraud, or coercion. They are a victim of trafficking. Just like if a child is willingly engaging in any kind of sex act, they are considered a victim of sexual abuse because they are not at the age where they can give consent. And this brings up a lot of questions around choice and consent, and who are we to say that someone, a child or not, can or can't be a prostitute or a sex worker? And, these are legitimate questions. And what I like to point out is just some statistics around prostitution, is that more than 80% of those engaged in commercial sex work are actually victims of trafficking, because it's very easy for a trafficker to make it look like it's willing, or it's a person willingly engaging in sex work, and they're threatening their victims to act like they want to be there. And those who maybe are actually involved in sex work independently, there's no trafficker, usually there has been a history of abuse and victimization. So we have to look at, okay, what is behind that choice? And is it truly a choice, or is it a lack of resources and opportunity and response to victimization? So important to keep in mind as well. But who are the victims? So victims can be anyone, any age, race, ethnicity, sexual orientation, background. An organization recently shared that they have helped victims from 2 months old to 77 years old. So they truly can be anyone. But there are some populations that are disproportionately affected by this issue. And as we look at this slide, we can see, okay, there might be different vulnerabilities that occur in these communities, whether it's the vulnerability of past oppression or discrimination, or being isolated from a community because of a disagreement, or needing work to provide for family, or just having a background that lays the groundwork for future trauma and future hurt. These can create extra vulnerabilities to someone being trafficked, because traffickers look for the vulnerable. And again, this could be someone who comes from a very loving background where they have not experienced oppression or discrimination, but they simply are unaware of trafficking and the lures and tactics. And so we don't want to come up with an idea of how a victim might present or what their background might be, because then we will miss indicators. But it is important to understand what vulnerabilities might be in place for a victim, and to understand that traffickers are looking for a vulnerability so they can gain trust around it in order to exploit a victim down the road. And that's why we also like to talk about, adverse childhood experiences, because the more ACEs someone has, the more likely they're experiencing PTSD or complex trauma, and the more at risk they are for future exploitation, like trafficking. And these kinds of experiences can also lead to misdiagnoses of victims, and seeing it only as, a mental health situation when there are a lot of other factors involved. And it might just be presenting as, bipolar or dissociative identity disorder, but there's more going on behind that as well. And so this is where we just encourage digging a little deeper and seeing what's really going on for a patient in this situation. Because many survivors say, that they felt misunderstood because they were struggling with mental health issues as well. And just like victims, traffickers can be anyone, but they look for and take advantage of vulnerabilities. But they, can be those partners and spouses. They can be family members. Familial trafficking is at 40% in the US. So a lot of victims aren't leaving their homes or their, schools or their day-to-day activities. So being educated in our context is really crucial in that respect. It could be friends. They were likely victimized before and are now promised to not be hurt as much if they bring in other victims. And so there's this layer of victimization that occurs as well. But all this to say, we don't want to conjure an image of a victim or a trafficker, because again, we're going to miss those indicators if we do that. And so we want to have an open mind, because otherwise it can be easy to say, oh no, this person wouldn't get hurt, or this person wouldn't be a trafficker because of X, Y, and Z. But often traffickers are well-respected members of our community, and victims are those that we would not expect. So just keeping that open mind. Okay, so now I want to take all this information that we just learned about trafficking, who it involves, how it occurs, and make it relevant both to, us in the US and you all as healthcare workers. And so I want to start by just acknowledging that human trafficking has been reported nationwide. So it's something that every community experiences. And child sex trafficking has been reported in all 50 states. And when we look at Virginia in particular, these numbers, again, are from the latest statistics from the Human Trafficking Hotline. And again, they're lower than the reality, because this is only the data that the hotline is getting from those who are aware. But 583 signals were received by the hotline in Virginia, with 199 of those contacts being from victims or survivors. And then out of that data, 140 cases were identified that involved 179 victims in those cases. We saw cases of sex trafficking, labor trafficking, in some cases where sex and labor trafficking were happening at the same time to the same person. And we know that this is also an issue in our state because the Virginia State Police are addressing it directly. So Virginia State Police have their own human trafficking unit now, where they are putting officers in charge of regions in order to directly address this issue of trafficking, which is really important because we're still in the process of helping to inform law enforcement officers on how to address this issue, and helping make them aware of the issue to effectively intervene. And like we touched on earlier, there are a lot of different settings where this is happening in Virginia. So for sex trafficking, the top venues, again, were in those massage and spa businesses, in hotels. We actually had legislation passed in recent years requiring hotel workers to be trained in trafficking because of this. It happens a lot through pornography, through escort services, and in residence-based brothels. Now, escorting is important to highlight, especially if you are in a college town. So I'm in a college town, and so I always like to highlight escorting because we're seeing a new occurrence with college students called sugaring. And this is a form of escorting where students are becoming an escort or a companion for someone in order to pay for their tuition, without realizing that this can sometimes be a front for trafficking or can quickly turn into a dangerous exploitative situation. Now, we also see with labor trafficking in Virginia that happened mostly through domestic work and construction. But when we step back and consider the vulnerabilities that can lead to trafficking, both the vulnerability of being unaware, the good vulnerability of just desiring love, or the vulnerabilities of needing a specific survival need met, if we think about all those things and think about the vulnerabilities we see in our communities and resources that are offered in our communities, we can quickly see that there is likely an overlap with trafficking, because it's a multidisciplinary issue that is involved in all these kinds of different contexts and different contexts of people's lives. Okay, so now to get more focused on why we're here talking about this issue is, okay, what does trafficking have to do with your work in the healthcare profession? And I like to start by sharing a survivor story that highlights the three I's that occur when we discuss health and human trafficking. So as I read the story, I just want you to keep in mind these three I's of injuries, illnesses, and impairments. So this survivor shares, when I turned 13, I'd had enough of the abuse in my home and I ran away. I didn't know where to go, so I went to the center of town and stood by town hall. A man saw me there and said he was looking for a protege. I didn't know what that was, but it sounded fine to me. He said that I could stay with him, and when we got to his house, he pulled out a bottle of gin and had me drink. The next thing I remember is waking up sick and wet and hurt. The next day, he took me out on the street and told me what I had to do. When I said I didn't want to, he threatened me with a gun and pistol whipped me. And that's how I got into this life and couldn't get out. Over the next year, he hit me, punched me, kicked me, beat me, slashed me with a razor. I had forced unprotected sex with customers, got pregnant twice, and had 2 abortions. I have many injuries and many illnesses. I have hepatitis C and STDs, stomach problems and back pain, and a lot of psychological issues. I've overdosed on drugs twice and was taken to the hospital where they saved me, but then released me back to my pimp again. Now, when we step back from a story like this and think about, okay, is this the common story? Is this story unique? Unfortunately, we found that the answer is no, the story is not unique. As I mentioned earlier, we are now going to talk about the health consequences of human trafficking that were discovered through a series of focus groups and through the study that Laura created and conducted. In this study, survivors were asked to report on 200 plus discrete physical and mental health conditions. And this happened through these interviews, through data, and through questionnaires. But survivors were presented a series of open-ended questions on, whether they sought healthcare while they were being trafficked, what types of facilities that they sought medical treatment from, and whether healthcare providers seemed to be aware of their situation or asked about their situation. This is 2 pages of the 4-page survey that survivors completed, and over 300 survivors were interviewed and completed this survey over a 2-year period. And in the survey, they were asked questions categorized by body systems, so neurological, gastrointestinal, respiratory, cardiovascular, reproductive, and more. It also covered a basic set of psychological symptoms and diagnoses. And it asked about violence during trafficking. It asked about substance use and abuse, including overdose, and again, whether healthcare was sought. And from this study, it was found that 87% of victims reported contact with a healthcare provider while they were being trafficked. 95% of victims experienced some sort of violence or abuse. And, this really sheds light on why survivors are leaving these situations with so many different mental health issues as well, and the complex trauma that comes with that. And 71% of victims reported at least 1 pregnancy while they were being trafficked. And just to make a note, there is this trend with traffickers as well, where they will impregnate a victim on purpose to maintain control of them with that child, to say, you have to do this for the child, or I'm going to hurt the child if you don't do this. And there's also studies are showing that multiple abortions and forced abortions are shedding light on trafficking situations as well. So just something to keep in mind as we continue discussing this. But from the study, kind of three main issues were uncovered of, how healthcare providers can help when it comes to this overlap. So first, it has to do with identifying individuals who are being trafficked and offering appropriate treatment and referrals and mandating or mandated reporting when necessary, working with others in the field to develop best practices and programs to address this issue, and then connecting with the community to offer the referrals and the help that traffickers need that might be outside of the scope of healthcare that you provide. And I think it's really helpful to, while this list is not exhaustive, to see that, the services that are provided in the healthcare setting are the services that survivors are looking for. And the populations that are most often seen in the healthcare setting are the populations that can be most often vulnerable to trafficking. And so working on just identifying this and looking upstream can help healthcare providers prevent and intervene effectively when it comes to instances of trafficking. So now what I want to do is take us through some indicators or red flags of trafficking. I'm going to show you a broad list of these indicators. Don't worry, I'm not going to go into each and every one of these points, but this is just to give you an idea of there are a lot of different indicators you might see physically, behaviorally, environmentally when working with patients who are experiencing trafficking. But what we're going to do is we're going to break this down into what are the indicators you might see, when scheduling an appointment all the way through to examination. So really taking it step by step according to a patient visit. And I do want to start with a case study. And all of the case studies that are presented are drawn from focus groups with survivors of trafficking and represent actual interactions that trafficking survivors had in the healthcare setting. So in this situation, a young woman comes to the clinic and is clearly distraught. She says that she thinks she's pregnant and asks for a pregnancy test. After examination, the doctor finds severe bruises around her abdomen, and she confesses that her partner is not happy about the pregnancy, but she doesn't want to say more. So while this patient does not say so, her trafficker had beaten her around the stomach when he discovered she was pregnant. And I start here with this case study because it's important to understand that it's not likely a survivor is going to come out and tell you exactly what's happening to them. But it's more likely that you're going to see indicators, and those indicators are going to open up opportunities for conversation and assessment, because indicators don't mean trafficking is definitely happening. A lack of indicators doesn't mean that it's not happening. We might not know exactly what's going on, but as we see indicators, this can help guide our interaction with a patient to start to uncover what's happening. And so let's go ahead and dive into what you might see when scheduling an appointment, because each person in the healthcare setting has a role to play when it comes to seeing indicators and helping patients. So when scheduling an appointment, some indicators of a trafficking victim could be that they're not the one making the phone call, someone else is making the call for them. Or if you're on the phone with them, you can tell that someone else is listening in, that, there's a lot of pausing between your questions and their answers, allowing someone else to kind of feed them the answers. You might hear whispering, and you might experience a patient just handing the phone to someone else to talk to you. So just that idea of like, they're not the ones giving you the direct information. And then other indicators might come up as they're describing what they would like the appointment for. And so this could be, requests for STI testing, pregnancy and abortion-minded concerns, again, as multiple abortions and forced abortions are indicators of trafficking. It could be requesting contraception. And what I mean by this is they're requesting a lot of different types of contraception or a very large number of condoms, something that's just like, oh, that's kind of odd, out of the ordinary. They might talk about anogenital complaints. They might discuss some sexual assault, or they might even start to disclose some violence that they've experienced from a partner. But something else to keep in mind during this time is if you realize the person you're speaking to is not primarily fluent in English, this is the time to offer an interpreter, because you don't want someone who's with them interpreting, as they could be a trafficker and might not interpret accurately. So it's important that you offer interpreters free of charge, and that you let a patient know that you're offering that, and that you ask, like, what is your language preference? And make sure that interpreters are being trained in how to interpret when it comes to human trafficking situations, particularly. But at this point, what's crucial is that the scheduler is not too assertive or judgmental, because the goal is to get the patient to keep that appointment so you can assess them further in person. And, at each point as we go through these indicators, just keep in mind, you might hear different terms and language used that is indicative of trafficking as well. Terms like wifey, which would be another girl victim. It could be saying things like a square, which would be like law enforcement, or talking about the life or daddy or boyfriend, that kind of thing, to keep in mind as well. So the next point of contact at reception can also open the door to some indicators. And so some things that you might see at reception is that the patient doesn't have their identification on them, or someone else is carrying that for them. Again, holding a passport or holding someone's passport in Virginia is considered abduction. Maybe they're escorted by someone else who is speaking for them, or they're looking to that person to make sure that the answers they're giving you are correct. They're probably not going to make direct eye contact with you because they've been told, don't talk to others, don't look at others, don't do anything that could give this situation away. If they give an answer that the person with them says is wrong, they're probably going to look worried. They might not be able to list an address. The person with them might be the one actually filling out their paperwork for them. They might be disoriented or wearing the wrong clothing for the season or place. They might refer to the person with them as a boyfriend or girlfriend when that other person is not an age-appropriate partner. You might see signs of physical abuse at this point, signs of self-harm, or just that the patient is hyper aroused, right? They might be fidgety, they might be, that could be from drug use, that could be from anxiety, or a combination of those things. And you might also notice in reception things like one person is bringing in multiple patients over time. And this one person could be the trafficker. This one person could be what is referred to as a bottom. So this is a victim who has now entered into recruiting other victims so that they're not hurt as much. And for labor trafficking victims, you might just notice signs of exposure to chemicals, pesticides, or other hazardous working conditions. Now, when indicators present themselves, the next immediate step is to let whoever is working with the patient next know what you've seen. So if scheduling, you let reception know what you've seen, so they're prepared when that patient comes in. At reception, you're letting the nurse who's taking them back know what's going on, and down the line, because you just want everyone entering into this patient visit aware and informed so they can interact effectively. But once you get to the point of taking a patient's medical history, other indicators are going to reveal themselves as well. And because of this, it can be good to have some best practices in place in your healthcare setting. Like, we only see patients alone, and you can cite client confidentiality and things like that, or saying, we need to do another test or something to kind of remove a suspected victim from a trafficker. But if someone is insistent that, we're going to leave if you don't let us both in the room, you might have to hedge on that a little and assess as much as you can with the other person present. But again, some signs that are going to come up at this point is discussion of multiple sex partners, very large numbers, multiple unintended pregnancies, multiple miscarriages and abortions, multiple STIs, talking about using contraception serially or simultaneously, a lot of use of the morning after pill, a lot of use of misoprostol, talking about a long history of UTIs and infections. They might refer to their substance abuse or refer to homelessness or other vulnerabilities. And what's gonna happen next is you're probably gonna wanna, start with the exam. And we'll talk more in a couple slides about how to go about that in a trauma-informed way. But while you're actually examining the patient, you might start to see signs of physical abuse or injuries from violence. You might see tattoo markings. So a lot of traffickers will quote unquote brand their victims. And that can look like tattoos of money symbols, a crown, something that says like daddy's girl or a trafficker's name. And often you might even see these tattoos in visible places because traffickers want to make it more difficult for their victims to leave and even get other jobs because of these tattoos. But you're also going to see maybe needle tracks from addiction, gynecological complications, pelvic pain, foreign objects in the vagina. A lot of traffickers, to save on money, will force their victims to use things like a makeup sponge instead of a tampon. And then, of course, this causes a medical issue that they have to be seen for. Communicable disease, dermatological issues from living in unfit conditions, malnutrition and dehydration. You might be seeing signs of self-harm. You might hear about suicidal ideation or attempts, and you're going to be seeing just that they're maybe in a very obvious state of needing food and clothing and things like that. And sometimes it won't always look that obvious, but it could go both ways. And one thing to keep in mind too is you might see indicators that bleach has been used in private areas because some victims will bleach themselves between buyers to try and kill any kind of infectant. But at this point, it's really important for providers just to be demonstrating a high level of care and compassion and consistency through a trauma-informed approach that understands that even a basic exam or even just like a touch on the arm could trigger the complex trauma in a victim. And you also want to be using very simple, straightforward language when you talk about the exam or medical issues, because some survivors have had interruptions in education. But more importantly, when you're experiencing the kind of trauma that a survivor is, it's very difficult to process a lot of information. So you want to keep your language simple and to the point, and just build that trust and safety so that a victim could get to the point of telling you what's really going on. But also just think about, okay, what am I seeing here? If there's something like suicidal ideation, is there a hold that I could put this patient on in order to get them the services they need? Or, can I offer help for sleeping? A lot of survivors have interrupted sleep as a way of maintaining control over them from their traffickers. So putting them on a hold, allowing them to get some sleep and rest in order to assess them in a more effective way can also be helpful. So just keeping in mind, what are some strategic next steps that can be taken? But another very common question and logical question is, okay, well, why don't victims seek help from healthcare providers during these exams, during these patient visits? If so many trafficking victims are being seen, why aren't they disclosing? And there are just some barriers to disclosure for victims and from healthcare providers. So for victims, there's a lot of fear of authorities of any kind because of the threats that traffickers have made. They might fear that a trafficker will hurt them if they find out or hurt someone they love. They might fear being deported or maybe being returned to an abusive situation they left before being trafficked, and just fear the cause of harm to loved ones. They might not be aware of their victimization to be able to disclose it or understand their legal rights in the context of, deportation or other contexts. They might not have their ID, or there's a language barrier that causes a lack of disclosure. And there's also that matter of trust not being there. Trust takes a lot of time to be built when you've experienced this kind of abuse or past abuse, when you're maybe living a transitory style of life where you don't see the same doctor over time, or maybe a victim is feeling a lot of shame and that's causing a problem in communicating what's going on. They may have been forced to commit crimes for their trafficker, and so they're nervous about that. They may have had previous negative encounters with healthcare providers. or they're just experiencing that trauma bond with their trafficker or other victims. So there's a lot of things going on in a survivor's mind that can make it difficult to disclose. And so just having healthcare providers being aware of that in order to create that trusting atmosphere around that can be really helpful and make a difference. And also understanding some of the barriers that come from the healthcare provider side. And a lot of these things happen just in our subconscious, and we're not even trying to communicate these things, but it can happen if we're not thinking about it. So, not maybe having a trauma-informed approach for trafficking victims who are clients, maybe not having the knowledge of human trafficking that would be helpful, or knowing the laws that can help guide that interaction, misdiagnosing a case as, a mental health issue or something else because you don't understand that can be at the top layer of a trafficking situation, maybe not having referrals in place or just fear of violating HIPAA. And it can also come out in things like body language and facial expressions, unconscious bias that, survivors have reported feeling like they were experiencing a bias from providers based on, perceived involvement in prostitution or not being married or, being pregnant, and a provider kind of indicating they didn't think they should be pregnant, that kind of thing. Sometimes it can be easy for a person interacting with a trafficking victim to think that they're lying or they're hostile or, they're just not truthful. And that's usually because they're having a trauma response, and traffickers have told them exactly what to say when asked certain questions. So it sounds rehearsed and like they're lying. And also just not believing it's maybe your role to get involved. And also, of course, healthcare providers have a limited amount of time. You all are seeing and treating and helping a lot of people. And so it's often the very strengths of a healthcare provider that can cause a barrier unintentionally of, hey, we're offering as much care to as many people as possible. We're being non-judgmental, non-invasive, and those are good things. But just keeping in mind that if you're seeing indicators of trafficking, it can be good to pivot that approach to, okay, how can I spend a little more time with this patient and assess what might be going on and what resources can be offered? So I want to take us through now some ideas on how we can overcome the barriers when working with potential victims of trafficking. So this has to do with survivor-centered or victim-centered trauma-informed care approaches, recognizing our unconscious bias, building trust and meeting needs in practical ways, and then utilizing community connections. So it's crucial that any response to trafficking be victim-centered, which just means that the safety and well-being of the victim is our top priority. And so what a victim is wanting, what they're needing takes priority in all matters. As we approach this victim, we're doing so in a way that's going to minimize re-victimization or re-traumatization. And it's also taking a systemic focus on the needs of the survivor that might be needs beyond what can be met in the healthcare setting. And so this is just really crucial that we start with the assumption, especially when we see responses from a patient that are startling or confusing, that we start with the assumption of, okay, there's probably a trauma response going on here. And so how can I approach this with that in mind? And some just practical do's and don'ts, for any healthcare visit, but especially if you're seeing indicators, is be sure you're identifying yourself with the patient. You're explaining how you can help, that you're listening actively, you're empathizing, asking open-ended, non-judgmental questions, that if you realize a survivor is sharing their story, that you minimize the number of people they have to share that story with, as that can be traumatizing, that you're connecting that client with services, and you're encouraging follow-up visits as well. And of course, just avoiding things like derogatory names. This could be using phrases like illegal alien or prostitute. And it could also, just be keeping in mind that the accepted term for commercial sex workers is sex worker at this time. Not making negative assumptions about their involvement in crime, and realizing maybe they've been forced to do something they don't want to do. Viewing individual as a victim first, and then seeing, is this a case of legitimate sex work, or is it a case of someone being coerced? And then, being sure we're not being dismissive, we're not blaming victims or pressuring them to talk, or, just saying this is all in your head or due to stress. So this is just an approach that requires a lot of patience and empathy and compassion throughout the visit. But again, some language around these do's and don'ts is saying things like, tell me more about that, acknowledging their feelings, validating those feelings, using the kind of language they're using, encouraging them, affirming their strengths. And I love this listen and wait of just asking yourself, okay, why am I talking when you're talking? And then taking the stance of listening more, and avoiding questions like why questions, or, blaming their perpetrator because they probably have a bond with them, asking, why were you involved in this, asking personal questions that are abrupt, like how many people have you had sex with, what were you paid, saying you're better than that, all those things, because that can tend to shut a survivor down from sharing. Now, I do want to offer some resources at this time that can help as you're going through assessment and seeing, okay, I'm seeing these indicators of trafficking. How do I assess if it really is trafficking? And so I have a QR code here for what's called the PAIR tool, which is a trauma-informed approach for victim assistance in the healthcare setting. And as you're going through these different tools that I'm going to offer in the next couple of slides, you want to keep in mind what is most important to the patient. Am I asking questions like what they want, what they need? Because it might be something again, as simple as, I need help sleeping. You can ask them, can you tell me why you're not sleeping, to further assess, is someone waking them up and interrupting their sleep? And then letting those answers guide you in how you respond, and first putting them on hold, getting them some sleep, and then assessing from there. And a caveat to this PAIR tool is you'll see that it discusses sending survivors with resources, but please do not do that. If you send a survivor with resources and a trafficker finds those resources, that can put them in danger. So it's better to just or have them memorize like hotline numbers, that kind of thing. But another tool that can be used, if you scan this QR code and go through this document, you're going to find tools for assessing sex and labor trafficking of youth, as well as sex and labor trafficking of adults, because usually we're going to have to use a couple of different assessment tools when uncovering trafficking. But as you're going through this, again, remember that if a victim is forgetting things or reordering things or seems deceptive, it's not because they're lying to you. That is usually from a response of complex trauma. And so keeping that in mind, that if you feel like they're lying to you, that's probably not what's happening. They're probably still trying to see, can I trust you to go away from the script a trafficker has given me? But as you're talking to victims, also gauging, okay, do they need a break? Are they being so triggered that maybe we need to practice some sort of grounding technique? And just keeping in mind, a survivor wants to be helpful in the situation, but sometimes their brain and the trauma they've experienced are just taking them a different route. So just taking on the perspective that, they are seeking to tell the truth, even in the midst of this complex trauma. And also keeping in mind that if something they say sounds too crazy to be true, it probably is true. I was at a law enforcement training recently where the trainer was saying, I used to tell victims, I've heard everything, so you're not going to scare me by something you share. And he's like, but I've heard something new almost every time I work with a survivor. And so there are some pretty extreme situations that we probably haven't even considered that might get told to us. So now I want to take us through another hypothetical scenario to kind of break down how you might practically interact with a patient in this assessment setting. So, during an exam, you find out that Sarah, who's a minor, is being sex trafficked by her stepfather. And you're a mandated reporter, so we'll need to call law enforcement or CPS. And the police and CPS will have their steps to take, like interviewing and obtaining a sexual assault evidence kit. But Sarah says no to alerting authorities. So what do you do? Well, there are some things to keep in mind as you go about this patient interaction. So first, you want to acknowledge and explore Sarah's reluctance, explain the reasoning behind alerting authorities and testing for sexual assault, continuing to listen as Sarah responds to this, strategizing with Sarah, and involving Sarah in the next steps. So when we're talking about these steps of strategizing and talking through different possibilities with a patient, again, remember, keep the language simple and direct, because in high stress situations, processing goes down for all of us. And so we don't want to force someone to go into that high functioning processing by using complicated language. So you want to let Sarah know, like, hey, can you tell me a little bit about why you're concerned about me telling, police or CPS, be specific about the authorities you're alerting. She might feel like there's no point, what's happened has already happened. And acknowledging that you hear what she's saying, there are good reasons for telling police or CPS or doing these examinations, and let's talk about that. And at this point, you're probably going to get some resistance from Sarah of like, just give me the test. My stepfather's probably out there already angry that this is taking so long. And so at this point, because we are dealing with a minor, you have to share about mandated reporting, but in a way that still offers Sarah some choice and control. So letting Sarah know, I do have to report this to police or CPS, but there are some ways I can go about this. I can call them with you here. I can call them and let you talk to them. We can have it on speakerphone. What would make you most comfortable? So even in situations where there isn't a lot of choice, you can still offer some options and control. Now, another aspect to keep in mind in this kind of approach is that it is grounded in a set of 4 assumptions. So a healthcare setting that's trauma-informed is going to realize the widespread impact of trauma, recognize the signs and symptoms, respond with fully integrated policies and procedures, and resist re-traumatization. And in all of this, there is a conscious effort to offer the patient choices and control and to seek truly informed consent with transparency. So one more hypothetical situation in talking about trauma-informed, victim-centered approaches. Suppose you have Carmela, who is a 20-year-old female who has scheduled a pregnancy test. And the receptionist let you know that she came in with a man who seemed very angry, and she appeared to be intimidated by him. Eventually, the man left the reception room, but he's still in the parking lot. So when you enter the exam room and introduce yourself, you notice that Carmela is sullen and irritable, and she glares at you, clearly angry, which of course can evoke that initial response of like, okay, what's going on? Why is she acting like this? So in this situation, you want to maintain that open, non-judgmental, and calm demeanor, demonstrate concern and give choices and control, explain the process of the patient visit and the voluntary nature, actively listen, and obtain informed consent. So you want to introduce yourself, let Carmela know who you are, what your role is, what your job is, demonstrate care and concern, say, are you comfortable? Can I get you water? And then you want to sit in a chair that, maintains like eye level, you're at the same, height, you're not looking down at Carmela or anything, and you're showing engagement in your body language, maybe leaning slightly forward. And so, you're showing like, hey, I'm here, I care, I'm being attentive to you. One caveat though to eye contact is not everyone enjoys a lot of eye contact. So taking that on a case-by-case basis is important too, both for individuals who aren't comfortable with that, but also cultures that view eye contact differently. But in this interaction, just let Carmela know, again, in simple, straightforward language, I'd like to ask some questions to understand how I can help you today, but you can choose to answer any, all, or none of those questions. It's completely up to you. Asking Carmela, is it okay if I ask you questions? And do you have any questions for me first? And if Carmela agrees, but still seems like hostile, you can maybe ask Carmela, you seem uncomfortable. Like, am I right that you are uncomfortable? And can you tell me what's making you feel uncomfortable so I can help ease that discomfort? And in all of this, you're just inviting Carmela to share how she feels, and you're letting her know that you care, that you want to give a voice to that, and that you want to build that trust and safety. Okay, so that is a lot for survivor-centered trauma-informed care. And the next three are kind of, linked to this and a little more straightforward. So we also want to be sure we're recognizing unconscious bias in these patient visits. And unconscious bias, as most of us know, those are just the social stereotypes that we come up with that are often formed outside of our conscious awareness. And it happens outside of our control and occurs automatically with our brain making a quick judgment. But we have to be aware of this because it can result in micro behaviors that can, send micro messages that create these, inequities and the communicating inequity, or can also communicate affirmation at times. But it's really important that we think about this because survivors have revealed how unconscious bias has, impeded their ability to get help from healthcare workers. One survivor shared, I had a pregnancy test come back positive, and they assumed that I wouldn't want to keep the pregnancy. So instead of kind of getting a gauge on how she felt about that result, they kind of just went into, adoption options, abortion options. And, again, this happens sometimes outside of our control. And scientists estimate that 80 to 90% of our mind works non-consciously, or, in this unconscious bias mode. And so one way to address all of this so that we're not creating a barrier with potential victims is to practice making this unconscious conscious. And this can be done through what's called a RAM, or recognize, address, and manage model. And so in this model, you are recognizing, first of all, that we have unconscious bias, that you're becoming more aware, you're seeking opportunities to learn about those who are different from you and cultures that are different from you, and supporting diversity and inclusion events in your healthcare setting. And then you're addressing this through training on unconscious bias by learning more about stigmas associated with sex and labor trafficking, so you don't apply those in a healthcare visit. And that when you see unconscious bias in your colleagues or staff, that you're addressing it by addressing the behavior and not the person, because you don't want to put those staff down either, but take it as an educational opportunity. And then manage this by seeking out positive survivor stories, learning how you can take the unconscious and make it more conscious, and then creating opportunities for staff to learn about this together. One survivor suggested, have a lunch and learn with a survivor who can share their story, share their experience in the healthcare setting to help influence how you navigate this. So a hypothetical scenario I want to talk about with unconscious bias is, suppose you're leading a suspected victim of trafficking to the exam room, and you and the victim hear two staff members look at you and say loudly, geez, if anyone needs birth control, it's that one. She's been here 3 times in the last 2 months. Now, there's no gold standard on how to address a situation like this, but some ideas are to, acknowledge the harm done, clarify that this is not behavior that you support in this setting, and address the source of the harm. So, bring the patient into the privacy of the exam room, apologize for what happened, let them know, hey, this is not something that we're okay with here. And then address it by speaking with these nurses privately and just letting them know, like, hey, I heard what you said, the patient did too, and just encouraging them that, we don't always know the situation that a patient is in, and we want them to continue coming to us for help, especially if they're in a situation of harm and trauma that we don't understand, and letting them know, this behavior is something that's going to drive them away rather than welcome a patient in. And finally, I want to look at, okay, how do we start to build trust and meet needs in the healthcare setting? So because of services offered by healthcare professionals and the overlap with human trafficking in the healthcare profession, you are probably realizing that you all can be true first responders to the issue of trafficking. And as you think about that and you think about your potential to treat and reach victims, this can really inform kind of the human trafficking response plan that your healthcare setting takes. So this plan is going to start with the scheduler, just like indicators did, you know? So you're going to start with schedulers, making sure everyone from schedulers to doctors to any staff in that setting is trained on trafficking and indicators and how to help survivors. You know, having waiting room practices where maybe you have posters up about trafficking and what the indicators are that can help inform victims who might not be self-identifying at that point and inform them on how to seek help. This could also be put up in bathrooms and exam rooms, being sure that nurses and doctors are prepared to offer that trauma-informed, victim-centered approach care throughout the medical exam and how they take a medical exam. And then being sure everyone's prepared in how to offer those referrals and follow-ups with victims on a case-by-case basis. So this process of building trust will also happen not just through what you offer in the healthcare setting, but how you interact in that setting, like we've talked about. But this can come out through just the interactions, the simple words and interactions you have. So when scheduling, just the simple language of like, let's find an appointment that works well for you, showing, you know, I care about you, I care about making this convenient for you. Maybe in the waiting room, if it's taking a little longer to be seen, you know, letting them know, I'm sorry for the wait. Are you comfortable? Can I get you anything like water? Again, just demonstrating care and compassion for them as a person. And then in the exam room, letting the patient know that you appreciate how they've answered questions, complimenting their memory, and then talking through, you know, hey, I would like to do an exam to help with what you've shared about, but let me share with you what this exam entails and what it would be like, and, you know, seeking that consent before you move towards that exam, which can help protect a patient who is experiencing complex trauma, but also empowers them to participate in their care. And you're also going to be building trust just by simply recognizing that there are a lot of needs a survivor is facing, both medical needs that you can help with, but also mental needs, physical needs, and social needs. And as we think about all these different needs a survivor has, that helps us remember, okay, community connections are vital. Referring patients is key in the situations of trafficking, because there are so many needs a survivor might have. But referral is only going to be helpful if you have a community network that is reliable and trauma-informed. So due diligence has to be done ahead of time. It can't be when the patient is there before you. You have to have this network in place and ready to go, where trust is built, where you feel like referrals are being trained appropriately in their specific, you know, field and how they help, and where you feel like they're practicing ethically, so you can refer with a good conscience. So how do you build these connections? Well, you want to locate different services in your area. You want to be proactive in reaching out, and then be proactive in maintaining relationships. And you can locate survivor help centers through looking up the DCJS website, by talking to the human trafficking hotline, by looking at, you know, do we have any local coalitions or multidisciplinary teams that are working on human trafficking? And if you're located in Central Virginia or the Shenandoah Valley, this is something that I could help with directly as well in helping you connect with different resources. But again, all this has to be in place before making those referrals and before you might see a patient experiencing trafficking. But making that trauma-informed referral is going to happen through a warm handoff. And what this entails is just thinking about everything a patient has told you about their needs, and, you know, asking them what their needs are, asking them what their desires are, and then empowering the client to participate in that referral process. So if you have a client who's interested in a referral, not just saying, okay, here's the information, make contact, but saying, you know, can we make that call here together? Would you like to make the call? Would you like me to make the call? Because that makes the client feel like they're not alone in this. And that empowers them to follow up on that referral. And, you know, this can be done with the language of letting them know, like, hey, based on what you've told me today, I have some ideas of resources for you. You know, are you interested in hearing those? And do these resources sound like they would actually help you? What would be of most help? But just being with them through that process. And also keeping in mind that when mandatory reporting is needed, that you do have to make that call, and then involving them in how you make that call and how you know, go through that referral process in a mandatory reporting situation. So I want to look at another case study where I'm actually going to ask for, you know, what your response would be. So in this study, you have a 16-year-old who comes to you as a healthcare provider with her grandfather, and he is requesting a pregnancy test for her. And when the grandfather is told that the pregnancy test is positive, he wants to leave, likely to get an abortion. But getting the client alone in the exam room for other testing, the nurse is reassuring the young girl when she starts to cry and confesses that her grandpa passes her around at his weekly poker parties. So, given mandatory reporting laws and kind of what we've discussed, I'd love to hear what are some like first initial responses or interactions or questions you would ask this survivor, and feel free to drop that in the chat.
I am here to help you is one that we received.
Absolutely. Absolutely. Yeah, and how might, if anyone has any other thoughts too on like, you know, given mandatory reporting, how would you communicate that with this 16-year-old and offer her choice in the midst of that?
We have a couple that say empower her to participate with reporting,
Yes.
and then try to reassure her that she can feel safe in the practice setting where she is.
Amazing. Wonderful, wonderful responses. Yes, all of those are completely true. And just letting her know, you know, I am here to help and I'm going to do everything I can to keep you safe. So I want to move us now into some final considerations. And I know you're probably thinking, you know, oh my gosh, 4 other sections, but don't worry, we're just going to breeze through just a couple of the federal and state laws on trafficking. How do we think about HIPAA when reporting trafficking, especially with adults? How do we think about this with medical records, and then wrapping it up? So first of all, the federal government does continue to pass legislation on trafficking beyond the Trafficking Victims Protection Act. And in Virginia in particular, being a victim of sex trafficking is an affirmative defense to prostitution charges, because we do see that a lot of victims are wrongly convicted because of misunderstanding the situation. So that is encouraging that there are some laws in place for that. And it is mandatory to report trafficking when it comes to trafficking in minors. And we recommend making this report at the state level to ensure proper follow-up responses. And just to keep in mind that we have to make these reports not just when the abuser is a caregiver, but when there's abuse, you know, whether it's the caregiver or not, you have to make a report when it comes to minors experiencing abuse or trafficking. And then you also have some leniency when it comes to being able to report for victims who are over 60 years old and anyone who's mentally or physically disabled. You are also mandated to report any kind of suspected exploitation in those situations. And this can help guide us when we think about HIPAA, right? Because HIPAA is designed to protect the patient and not to create barriers when it comes to reporting a situation of danger for a patient. So with HIPAA, obviously, when mandatory reporting is required, you have to go forward with that. But if there's imminent danger to a patient or the public, you can also report to authorities without patient consent and disclosing minimum patient health information. You know, maybe a patient does consent to disclosing patient health information, and you can, you know, connect them with organizations or call the hotline. But even if a patient does not disclose to, you know, saying, yes, you can report this, or yes, I want help, there are ways to still make a report that does not violate that trust and HIPAA obligation, you can still make a report without going into confidential or violating information. And so just some things to keep in mind. And this leads us into, how do you report this situation in a medical record? How do you record a trafficking interaction or suspected trafficking? So there are ICD-10 codes that are available, which will be sent in a follow-up email from this training, but it's very important that we document trafficking properly, that we're telling clients that we're documenting this, and that we're not recording things like a patient's story in the medical records, as that could be subpoenaed and be more harmful to a victim than helpful, and that we're doing everything we can to protect patient confidentiality. Because there are some concerns when documenting trafficking in medical records. There are concerns from a patient, and there are also concerns if a provider is not trained in human trafficking, if they're not trained in how to refer that patient to other helps and services outside of the healthcare setting, or if they aren't really fully assessing for trafficking. Or if, your medical record, whether that's, through, paper and pen, which I don't think many people are still doing that, but if your online medical records are not protected and don't have policies in place for data protection, that can also put a victim at risk. If you can't guarantee that a trafficker can't get a hold of that record, or if you can't guarantee that someone even within the medical setting won't take advantage of that information, then it's better to not record it, because this can cause a lot of backlash for a victim, where we've seen staff have propositioned victims when they found out they're a trafficking survivor, or where a trafficker has gotten a hold of the medical record and then caused harm to the patient. So some ways to navigate that is just to make sure that you're having policies around medical recording where data is protected, that staff are trained in how to manage this information, and that providers are trained in how to communicate with clients about what is being recorded, and just ensuring that all records are secure. And that includes any records that might be shared with another, medical facility, and making sure that those records are going to be secure once they move to that data, and their, own electronic health recording system. And so you just have to make sure there's safety along every part of that route. But I encourage you to take those steps to make sure that your systems and the systems you share information with are secure, because there are a lot of upsides to recording this as well, which includes informing people that, hey, this is the patient you need to take an extra careful approach with, and being trauma informed. I also want to go over some just brief protocol on if you do detect trafficking in the healthcare setting. And I'm sharing some QR codes as well to different resources that are helpful when helping a patient who might be a trafficking survivor. So first of all, if there's imminent danger, always call 911. The next step you want to take is making a report to the Virginia State Police. As you can see, you can make a call, you can text VSP, and then, of course, also reporting to the state level DSS for minors. And again, going state level to ensure those follow-up procedures are in place. And then you also want to make a report to the human trafficking hotline. Now, I say state police and hotline because the state police are going to be most effective in responding to the issue, and the hotline is going to be most helpful in collecting that data on the issue. And then Safe House Project is a great resource for getting clients placed in aftercare settings as needed, because they work with safe homes across the country. They help get survivors placed in those safe homes, and then they help cover the cost of any travel needed, food needed, clothing, that kind of thing. And they work with their safe homes to put them through a vetting process to make sure that they have ethical processes in place. And this is great in Virginia because we don't have a lot of safe homes. So working with Safe House Project is crucial. And if you scan that QR code, you can actually, fill out a form for a survivor, and they will get back to you in 24 hours to help with placement. And they have worked with a lot of healthcare settings to do this. And then you also, in the meantime, while you're waiting for placement, you want to work with those local shelters, making sure they're trusted, they're ethical, and that they can help house a victim until they get a safe home placement. They might also need a place to detox. They might need temporary holding for a minor. And it's crucial, especially in cases where it's not the caregiver who's the trafficker, to communicate, that a safe home is not a consequence to a truly caring caregiver, that it is just a resource for help and recovery. So just some things to keep in mind, some next practical steps to take. And in that follow-up email, it will be an even more in-depth referral process and next step process, which you can always reach out to me for help and guidance in that process as well, as it can be overwhelming. There's a lot we're learning about protocol and how to navigate this. So I'm always happy to help guide you in this. But in summary, I just want to encourage you all that this not be the last training that you go through on trafficking, that you seek out other training. There's a free training called IamOnWatch.org that talks about trafficking in the US and completely free of cost. It's 60 minutes. Safe House Project has a free pregnancy training that offers CMEs. It's 1 hour and we can help get you a code for that. Do want to just let you know that we do offer a letter of verification for those who are seeking licensure renewal through this training. So you can reach out directly to me for that letter that is can put your name in it directly, and to continue to be in contact with myself and others who can help guide you through these processes. Because at the end of the day, you all are the ones who are taking all of these steps to help survivors, and we want to make that as easy and just lift the burden as much as we can for you as you do this. Keeping in mind that when healthcare providers take these steps we've talked about, that it can truly save lives. We had one survivor share here, that they had been trafficked from a very young age. They'd been beaten, they'd been abused through this experience, but it was from a trained nurse who was able to take a trauma-informed care approach with them and let them know, it's going to be all right. Saying what you all put in the chat of, I'm here to help, it's going to be okay. That changed everything for the survivor and helped them feel comfortable enough to share what was happening. So all that to say, thank you so much for taking the time to be here tonight, to engage in this training. I want to share my information here. You can always reach out anytime, but I'm also going to just give you the next few minutes to share any questions you might have. I know we're just at time here, so I'll stay on a little later if we have more questions coming in. But yes, thank you again for your time. And I'm also going to just put up one last QR code if you don't mind sharing your feedback from this training to help in future ones. But all that being said, thank you, and I will welcome any questions.
Yeah, Anna, we did get one during the webinar.
Okay.
And I think you kind of talked on this a little bit, but they're kind of wondering, where do victims get help?
Yeah, great question. Like I mentioned, Virginia, we are, working on building resources. So a lot of it has to do with working with organizations like Safe House Project, working with the Virginia State Police Human Trafficking Unit, and then just assessing what are the unique needs and desires of this survivor, and how do we connect them to resources that make the most sense in that situation. So a lot of collaboration with other organizations.
Great, thank you. They would love to see your contact information again. And when we send the follow-up email to everyone, we will make sure we include Anna's information so you all can reach out to her for your letter. Everyone's saying thank you and did a wonderful job. Someone said, we get a lot of materials that can be posted around the clinic. The images are usually dark and dramatic. Does this connect well with survivors, contribute to biases?
Great question. Yeah, so what we're discovering more and more is it is better to have posters and flyers and things like that that don't have that dark imagery, or that imagery of someone being chained, or in duress, because that doesn't tend to connect with survivors as much. mostly because maybe that isn't what they're experiencing. They're not physically restrained, or it can just, kind of be off-putting if you feel like, oh my goodness, is that me? And so having the less dramatic, less dark imagery can be really important, kind of like the imagery that we shared like during the case studies and hypothetical scenarios. Like it had a person there, they were maybe looking out into the distance, but they weren't under duress. So yeah, we encourage using flyers that don't go that route. And there is, if you go to DHS's Blue Campaign site, you can actually order like free flyers that are in different languages as well, that have some imagery that isn't so dark and dramatic.
Do you also have any recommendations for materials that office staff, that physicians could keep for their office staff, since, this is mainly physicians and PA audience, so, their full staff?
Yes. Yeah. So I think as you're taking this information back to your own offices, kind of educating your staff as much as you can, but also, having like, there are, like Blue Campaign has like indicator sheets or different things that like are like, here are some of the indicators that like your receptionist can even have at their desk to remind them to be looking out for those things. And then just let them know, hey, if you see indicators like these, just let me know, bump that to the person who has gone through the training. So really just having those indicator cards and that kind of, first step information for schedulers and receptionists, and then having the policy of, okay, the next step when you see these signs is to let the person who's gone through the training know, so they can, take that trauma-informed approach.
Great. Do we have any more questions before we let Anna go? All right, it looks like that is it. We will be sending out the email no later than Friday of this week to you all, which will have Anna's information, the ICD codes that she mentioned, and then we will also link out to the recording of this webinar so you all can look back to it. We really appreciate you guys coming, and we'll be in touch.
Thank you all so much for your time. Have a great night.
Thank you. Bye-bye.